All right, ladies, we are live. Good morning, everybody. I'm so glad to have Susannah here this morning with Danielle and I. Really excited to hear what she has to say. Susannah is a physical therapist, and that's dear to my heart because I'm an occupational therapy assistant. I don't know if I told you that, Susannah.
Or me. Or me.
And she specializes in pelvic health and breast cancer rehab. She is beginning to really branch out into the world of breast implant illness. She wants to know more, and she really wants to try to help some other practitioners, learn and really have some integrative treatment, which is amazing. She is also starting an online program, which is so cool, called Kick Pink, which we're going to hear about today. And welcome, Susannah. We're so happy that you're here with us.
Thank you so much for having me.
Absolutely. So, and one other thing, Danielle, she is also going to be part of the
the breast health, the breast implant health summit.
Yes,
which is actually a pretty big deal.
It's a very big deal, and we're going to also in the next couple of weeks be talking more about that, which is really exciting for our community. So welcome. And also real quick, a disclaimer. Danielle, you want to hit us with that?
Yeah, so as always, you guys, this is our experiences and our joy to share what we think we know, and what we think we don't know, and in hopes to be a conduit and further your learning. And always check with your medical provider before whether we talk about supplements or exercises or whatever. And feel free to reach out to any of us should you want to find a specialist in your area or get more direct, professional, and appropriate cueing. So enjoy the conversation.
Awesome. So, all right. So Susannah, tell us a little bit about your background in PT and how you got started with your specializations there.
Yeah. So, I am a physical therapist, and back in 2011, I did my residency in women's health at Duke University. At that point, I became a CLT, which is a certified lymphedema therapist, and I started working with breast cancer patients a lot. My mother is a breast cancer survivor. She was diagnosed when I was 12 years of age. So I'm very familiar with a lot of the side effects associated with breast cancer because I was her primary caregiver at 12 years of age. She was a nurse. And, I remember flushing her port and, I know this, it was so many years ago, but even like giving her shots of Neulasta because she just was so tired of the medicalization that she was going through. So yeah, I was very familiar with those side effects, and yet we were pretty much treating breast cancer patients for lymphedema and maybe some shoulder dysfunction on occasion. So I went to the research, and back in 2012, it was scant about the side effects of breast cancer rehab, like breast cancer in general, rehab, shoulder dysfunction.
And it's scant now. It's scant now.
What's that?
It's scant now.
Oh, it is voluminous compared to what it used to be. So I wrote my first course in breast cancer rehab 8 years ago, and I've taught it internationally, taught it in Australia, New Zealand, and the United States. And because of COVID, I put it online. And I'm really stoked about that because I really want to start a global initiative pertaining specifically for breast cancer rehab. And definitely I'm so glad to have this conversation with you because we get to go into breast implant sickness syndrome. And although that is something that I have researched and do have some experience in treating, this is the conversation that we get to have where we get to put together pieces that just haven't been developed yet.
Absolutely.
Exactly.
I love it. So, tell us a little bit about, so a patient comes to you after having breast cancer. Do they typically come after their reconstruction or prior to that? How does that all kind of happen for you?
What I'm trying to promote is something called the prospective surveillance model, where a person who's been diagnosed with breast cancer goes and sees a rehab practitioner for evaluation prior to surgical intervention. So
Nice.
yeah, they get to take your circumferential measures. You have their weight managed, their weight, because over time, maintaining that, especially in post-menopause, is very important. And just baseline measures and function across the board for shoulder, but also in terms of enjoyment and life and who you are and getting to know that person prior to intervention.
Yeah.
And then that, I mean, you can have finished breast cancer treatment and that provider knows you and will be able to be there for you years to come. Because, I mean, research shows, there's research done by Schmitz in 2012 that looked at side effects of breast cancer treatment 6 years out with no intervention, and greater than 60% of participants had at least one or more side effect that is amenable to rehabilitation. So I think that everyone should be getting prehab. That is where
I love it.
I love that word.
But the next step would be early intervention. And I think that the people who are able to advocate for themselves the best are the people who have the side effects. And so for someone to know that they can go to their oncologist and say, I'm having this symptom, a lot of times they think it might go away once cancer treatment ends. For that oncologist to know who in their area they can send them to for early intervention is going to get them into the hands. I teach comprehensive rehab. We're not just talking shoulder dysfunction. We're talking sexual health, peripheral neuropathy, osteoporosis. So if someone becomes a Kick Pink certified practitioner, takes my course, they understand all of these things that they can look out for. So it's like the patient can kind of jump on the backs, not stay there, gets heavy. But and the therapist can look ahead and see what's coming and then turn around and say, right, if you experience this, then come back and see me because we need to screen for. And in a way that doesn't make them scared, but makes them feel aware.
And
now,
partnered.
there's a lot of work that needs to happen to make that happen. So I'm working on some initiatives to educate breast cancer patients directly. But one of the things that we do not want happening anymore are for severe, irreversible side effects. And walking to our doors as much, which has been which in the past has been like a mainstay.
Right.
I am breaking out in a sweat right now, and it's not menopause.
Hey, Danielle, go for it.
Oh my God. So that's a new term. I'm almost crying.
Prehab. I love that, Susannah. Prehab.
Yeah, prehab is a new thing for me, and I now have language to what I experienced with my body worker person, right? And so we have sadly a lot of not sadly, welcome, like I'm grateful to partner with people who have breast cancer and also have either BIA, ALCL, or breast implant associated cancers. I'm glad to be a conduit in that journey. I'm sad that they have to go through that journey. So we have different venues to affect that change. But I do find the prehab, as you defined it, to be significant for not only the cancer patients, but for the breast implant illness population, because when we have a flare, or we, 3 months after explant, we say, oh, my left hand, or my right, for me, it was my left hand, is still numb, blah, blah, blah. Like, that's a big deal to have someone to relate to be carried with, to have space held for, because it does change. But in that moment, as a BII or breast cancer person, I'm not thinking it's going to ever change. And I feel really, excuse me, Tara, here we go. I feel really fucked, right? So to have that space of safety, of possibility, of all of that is a big deal was a big deal for my healing. I can't speak for everybody, right? So my God, thank you for that. And I cannot wait for you to experience the women of who suffer from, like, I don't know the terminology because I don't like suffer, I don't like victim, and I don't like the term illness, right? Experience, yeah. Because it is, like, now that I'm on the other side, it was an experience, not one I wish on many, like, right? But it is an experience and it is a journey. And I'm not at the point where I would say, like, oh, I'm happy about the journey and, oh, I can't wait for another. Like, I'm not there. But to have that person in that safe place before, during, and after, professionally, as well as, I'm going to push it a little bit. There's a connection. There's a, whether it's a space holding, like a safe place that is more than professionalism that I was taught in PA school. Like, you be this way and you act this way and you don't get connected and you just, no, it's the offering of self to self.
Yeah.
That has healed me and my practitioners.
I have a few things that popped up during that. Do you mind if I talk timelines and ask you a question? Okay. So was your implant placement subpectoral, underneath the pectoralis muscle, or above it?
Below.
Below it.
Yeah.
So I could talk about the mechanics of that, but then I also want to get into why early is important for control of symptoms.
Well, so I'm a little attached to, like, the whole being of BII. So I would love to get you to talk about the before, but I'd also like to see if there's any questions, because, we can, and Tara's experience too is different than mine as far as physically. I think our implants were placed in the same way, but I'd love to check in, other than to speak about my stuff. And I'm glad to speak about my stuff if no one's talking. I'll talk all day long.
Yeah, no, we don't have any comments yet, so you guys go right ahead. I want to hear about it. Mine were under the muscle too, and I'm 2 years post explant, Susannah. And I just said to my husband this morning, he was hugging me, and I still have pain in the sides here that I recall having from the beginning after explant. It's like a burning and a soreness that just doesn't go away. So I would love to hear you speak on any of that.
Let's speak to that, because that is actually like a huge complaint that I hear. And for me, it's a lot of, for me, I look at that as lymph. Not that it is lymph, but that's all I know.
Right.
Lymph and viscera, right?
Yeah.
And that's also where I would have complaint. Wherever I've had pain before, I still have pain now when I get congestion.
Yeah.
Or tense,
so
or
let's talk about a couple of things. And structures are always interrelated, right? So if you do have swelling, then you do have some pressure on the nerve, which is going to irritate it and cause pain. But, like, just going back to the biomechanics of the shoulder, you have your pectoralis muscle, and it does this motion quite a bit.
Tara, do that.
I know.
Stretch it out. And doesn't everybody need post-op exercises? Yes. Okay.
You're pulling on me. I don't have full range.
Yeah, but that also makes my lower back hurt.
Yeah. Well, we're gonna. Yeah. There's so.
No, I don't mean to treat me. I'm just saying, like,
if you put the implant underneath the pectoralis muscle, then it's going to do two things. I mean, that muscle has its attachments, which one is on the coracoid process right here. Right underneath that is where the brachial artery and vein are. Okay.
Which is also the thoracic outlet.
Yeah, which is where the thoracic outlet is. And so if you have an implant taking up space underneath the muscle, depending upon the extensibility of the muscle to accommodate for that, that coracoid process can push down. You'll experience tipping of the scapula. You'll notice the bottom of the scapula kind
yes.
of. And then you've got pressure over nerves, veins, and arteries leading into the hand. So that's one thing. The second thing, talking about timelines, is if you did have prehab and someone was looking at your shoulder girdle stabilization, your movement of your scapula, what your glenohumeral joint looks like, then they can track that after surgery. They will give you, or most people don't know, but like I could give you and I teach other people exercises at appropriate timelines. You don't want to overdo it because, you don't want seromas and things of that nature to form. But that therapist, if they had a good knowledge of how to work with this patient base, would understand, okay, what kind of fascial work can I do in other areas while we're waiting to be able to do scar tissue mobilization? I mean, your whole body is a chain of fascia. And so have I had patients that have plantar fasciitis who have had breast implants? Yes, because it's a chain of fascia. And have I been able to work in this area and help relieve their plantar fasciitis? The body is complex and it's all interconnected.
Yeah.
And I'm talking about the pain upon the lateral aspect of the chest wall here. It could be because the pectoral nerves are being stretched. It also, let's talk about weakness. If those pectoral nerves are stretched, then not just breast cancer patients, but people who have had implants have reported a subjective, which means they themselves feel like they don't have the same strength that they once did. Now, those studies showed no real objective difference, but I mean, like the way that testing occurs, like that person is living with that shoulder function constantly. So maybe over time they get more fatigued more easily. But
just compensation
can also be if like the serratus anterior is lifted a little bit in order to accommodate that implant. That could also be a problem.
Or even like
yeah.
Or even so there's something I've recently thought about. I wouldn't say I know about it. And Chapman's reflexes or the neuromuscular connection, like your body is freaking brilliant. Like if there's pain, it's going to shut X off and you're going to compensate around that. So where I was getting stuck with my physical therapist in the past is I could do X, but how was I doing X? Mm-hmm. Right? Was I doing it with the muscles you think it is to do that, or was I compensating? Right? And I was totally compensate now. Like I think I'm brilliant. Our bodies are brilliant. We do this all the time. Like think about like when you get the breast implants. For some, they cut the muscle. You still function. You still can do a push-up, right?
Some people can. Most people can.
So I was going to say, like when I had my implants, I was so weak. Now, Susannah, you don't know my history, but I was a competitive bodybuilder, and prior to getting implants, and I
sorry, she was pretty badass too. Just saying.
I was pretty strong, and one of the first things that I noticed after getting my implants was that my strength was in the toilet, and not only that, but I work out a lot with my husband, and we would do chest exercises or even pull-ups, and I would say to him, the feeling of my muscles engaging actually made me want to throw up. It was this horrible, I can't even explain it. And he was like, that doesn't make sense. I'm like, I know it doesn't make sense to me, but I'm feeling this. It was so real. And then, so since having my implants out, I have gained that strength back, but I will tell you, my pec muscles are not in the correct position. When I engage my pec muscles, they're all the way here. They're in my armpits. Yeah. So my strength is different. I'm sure I'm compensating in certain ways. So I am strong, but it's so weird. That's all I can.
So did Dr. B?
I wish that surgeons would really look into the research more and not call certain surgeries non-consequential or deny that X and X side effects are, I mean, like
Just
I
can't even breathe. You don't even have to finish that. And like everybody else is like,
No, finish it. Do it. Say it.
oh, this is fucking reconstructive surgery just to get a breast implant in there, and they make it sound like, hey, why don't you come have a drink? Like, we're all fine. Like, we'll put these in. Like, it's all FDA approved. Life is good.
Plastics woo woo. Yeah. So one of the things that I want to do is put together some information for breast cancer patients in terms of choosing, if reconstruction is the choice that they want to go down, then they can understand what those reconstruction options are, so that they can have more intelligent conversations with the plastics rather than just doing the surgery that plastic feels most comfortable doing. No, go research all the plastics in your area, their outcomes. And if you're a swimmer, maybe don't get an LVF flap reconstruction. If you're a competitive weightlifter, talk to your patient about how implants can affect strength. Because you know what? That patient needs to understand what's more quality of life driven for me, having this implant or being able to do the sport that I love most. And you can't have both, but understanding that there are risks associated with your surgery is really important. And plastics need to step up to the plate with their bats.
Or patients need to have their bat and say, hey, I want to look this way. And what are the consequences? I said that though, like, I'm going to hold back. But one other thing to be productive about this call or whatever this thing is, when you do the EXPLANT, make sure they tack that muscle down or repair the muscle, or like mine was not repaired at my EXPLANT. And when I first did my first yoga chaturanga, I fell flat on my face because I had I kind of laughed, but like I could not do a push-up where I was like,
I'm sure that was shocking for you.
Oh my God. Yeah. Cause one, it was in a public place. And two, it was like, I was so excited to do it. And so I recently had a seroma removed, a bursa that was adhered almost 360, I think. And so I have some faculty around me now. And in that time, they repaired the muscle. Mm-hmm. But in the early days of this EXPLANT experience, I don't think they knew or thought about it, or like it wasn't a thing. But it is a thing. An inflammatory process post-EXPLANT I don't know where it's going to end up, but it is a thing, because I gained like a trajectory of health post-seroma removal that had no silicone, blah, blah, blah in it. But it was another surgery. And then they also fixed the muscle, where now I have access to better health. Like cytokines, whatever. I haven't put my brain around all that yet. And I still need physical therapy, which I will be seeing you at least, sometime in person, and then as well as online. But, there's things we don't know. We don't know what these things cause, and they make it sound like it's just okay. And then the breast implant population that you have, a good bit of them have gone through what they call expanders before implants.
Yes.
And those usually in the past have been textured. Yeah. And those textured implants have been associated with something called BIALCL, which is a lymphoma caused by the textured particles. And this is not the only device that this kind of lymphoma has been associated with, but it's always been associated with a device, right? And so when people have that lymphatic congestion, and I think it's important for PTs, yoga people, personal trainers, massage therapists to know that if your patient had a history of implants and they were textured, then what you may be dealing with, or like why or even chiropractors, right? Like if their adjustments aren't staying for more than 3 days, there's inflammation somewhere. What is that inflammation, right? If you're giving them what you know to do as their protocol, as their script, as you are their practitioner, then why aren't they getting better? There's inflammation somewhere.
I just had an aha moment with one of my own patients. Just off of what you just said.
Nice.
It could be, yeah.
This could be, those envelopes, they typically use them because they have less capsular contracture. You know what capsular contracture is?
I didn't hear you. They have what?
Oh, do you know what capsular contracture is?
Yeah, but you said something right before that.
I have a patient who I just had an aha moment with, who has some persistent recurring lymphatic cording. And then I look at her incisions and it's not cellulitis, but
yeah, they're kind of inflamed, not quite
inflamed. I wonder if she has textured implants in place.
Okay, so yes, it could be this, and this is something to absolutely work up. But what's interesting is that correlation is lymphatic congestion. So why the congestion? Is it the pressure, or is it the experience of the toxins and blah, blah, blah? Or is it a yeast overload, right? So when you see that kind of purpley pigmentation, and then maybe some people might, I'm trying to go through my clients, right? Some people have a raised, it's not keloid, but it's almost keloid. And they experience something with it, whether it's pain or restriction in movement, or you would think it wouldn't be that sort of bright pinky purple and wide spaced incision. Mm-hmm. Like that can be a number of things. One, it could be a lymphoma, lymphy stuff. It could be just lymphedema. It could be yeast overload. It could be
not necessarily. I don't think that it's necessarily lymphedema. She has persistent cording, which sometimes can be within the cord itself, and edema and cording can be related. But I would like for her to potentially, if you're to have some thought pertaining to differential diagnosis surrounding nutrition and yeast and things of that nature, maybe send her to you.
Yeah, and gladly coach, but we're trained in the same way. Let's rule out, let's see if she has textured, because that's like the big deal.
Exactly.
Right. And if she has, so I'm not a fear monger. If she has quality of life, if she has had textured, she needs to rule that out, period. Because that's lymphoma, that's cancer. That they've got to come out, and they've got to come out properly, period.
Would you say that for anyone that has textured implants? Like,
absolutely. The breast implant manufacturers may or may not be paying for it, but we can connect them to the Diana Zuckerman's group. I forget the full name, national. Yeah, we can post that in the thing, but we can figure out how. Yes. No, just yes.
Okay.
Those are like.
I second that as well. I had textured implants also, so I second that.
You're going to be second guessing that all the time too. Those particles fall off and get in your lymph system. Period.
Yeah, that from the moment of implant, that device is like sloughing off inside of you. So that my textured implant when it came out of me was not nearly as textured as when it went in, and I only had them for 3 years. So it's just starting to disintegrate. So like Danielle said, all of that texturing is just running through your bloodstream, and your body just, I think, fights harder, attacks harder with something that's textured, and that's why you see that increase in everything.
And that's why there's many reasons why you get contractures, but that is also one of them. It's just inflammation. Whether some people can be like, oh, it's bacteria. Oh, it's this. What? Fuck, it's a contracture. Why is your body protecting you from this foreign object?
Right.
So yeah, no, that's hands down. And honestly, like, and respectfully, I just want that person. Now, as a practitioner, how do I? And this is always a conversation that's tough, because I'm not someone who thinks that everyone is going to get sick with breast implants.
Right.
I also love innovation, but I love informed consent, and I love that they've done their safety data prior, right? So I don't like to, and I don't enjoy pushing someone towards surgery. And if they're having these issues, and you have breast implants. In my world, let's talk about removing them. And let's talk about what you need psychologically, neurologically, and aesthetically to be good with that choice and move them towards that. If they're happy with where they're at, then I'm okay as long as they're not thinking about breastfeeding, because that data's not solidified yet, right? So,
yeah.
Ooh, I digressed.
So going back a little
bit.
Sorry, Tara.
Going back a little bit, when you had said, trying to give women, making them feel almost empowered to know what their options are when they get that breast cancer diagnosis before reconstruction. I think that is a huge, huge thing, because from what I've heard from the women in our community who were post-reconstruction patients, not a lot of that has ever gone over. And, but I think that the challenge there is that when you're diagnosed with breast cancer, there is an urgency to get things moving and get that cancer out. And so it's almost like the patient goes into, that tunnel, like, I just have to, this is my end goal. I want to get rid of the cancer. I don't care what it takes. And so they just go through those motions. So I want to pick your brain a little bit, like, how do women get past that sense of urgency right away and take a minute and step back and say, okay, do my research, what's the right thing for me?
Right. Well, I'll tell you what, that sense of urgency serves its purpose at first. And over time, it's also something that can be very fatiguing to the person. So even though it seems like coming to a rehab appointment is like another stop, like I have another appointment. Mm-hmm. I mean, I have definitely walked into appointments where someone's sitting there like this, just like, PT, what are you going to do for me? And then they understand what my role is, and we get these baseline measures, and it is completely up to them whether or not they want to come back. But from that session, at least they understand what their next steps are. Because coming to PT for cancer rehab is not your 3 times a week visit. It's like you had surgery and come back in a month later. Okay, now we understand your surgical. Now that we understand your pathology report and what treatments are coming, now I can think for you, okay, you're going to be on radiation. I mean, you're going to have radiation. What are all these? I understand what all of these doctors are doing when a lot of times they don't understand how their treatments are affecting each other.
Right.
Okay, so like have I seen people who have had implants put in or expanders put in that are going into radiation? Yes. Is that scary? Yes. Do I let the patient know that? No, but I want them to know, like, okay, like they're going to be on more of a red flag region.
Right.
Whereas if someone has had a mastectomy, they're going in for radiation, they're not having their axillary lymph nodes radiated, it's going to be the chest wall, then I'll say, okay, if you experience limited range of motion or some swelling, come back in. I reevaluate, and then I determine if that's something where we need to up their visits. But prior to them starting like a chemotoxic agent, then I'm like, okay, I know that cisplatin has certain autonomic, sensory, motor side effects. So let's take these baseline measures and let's do, I'm here to help limit those side effects. So it's a much higher, it's a higher level of rehab.
Yeah.
Sure. And not only that, these breast implants have not been tested
on your thinking cap.
Yeah, absolutely. And now this is what you're doing, Susannah, with your forgive me, I'm forgetting the name, Kick Pink, with your Kick Pink, right? So you are actually doing courses. And what kind of practitioners are you working with to give them this knowledge? Because this is huge. This is like so innovative. This is so awesome.
Yeah, so I want to create a wave. Like there are other people out there like myself, like Lou James over in Australia. She has the Pink and Steel program where she's educating people about cancer rehabilitation. She's amazing. So are her practitioners. I'm doing Kick Pink, which is primarily it's breast cancer. But I have, in educating rehab practitioners, the wave isn't as big as I want it to be in my lifetime. And like
yes, it will be.
Advocate best are the people who have breast cancer. And you also mentioned, Tara, that people are in urgent mode. They're like, I want to get this breast cancer taken care of, knock it out, and get beyond it.
Yeah.
So they may not have a knowledgeable rehab provider in their area, or they may be hours from that rehab provider. So what Kick Pink is going to be is kickpink.com is going to be a website for people who have had breast cancer currently or in the past, have access to free information, coursework, and a membership site. So the coursework will pertain to, for example, if you're going in and you're getting a mastectomy and a lumpectomy, then I'm basically going to tell you what your progressive exercises might be. Work with someone who can help you with nutrition and creating those meals prior to going into having your surgery. Understanding the various side effects and what kind of conversations to have with your physician. And like have courses on sexual health and things of that nature. Then on that website, there's going to be, as Kick Pink grows, anybody who takes my course, which is a very in-depth, like the level 1 course, takes about a month. The first group just went through. They would be a Kick Pink practitioner listed on the site, and those people would be able to have access to those providers that they know have a certain standard level of knowledge and treatment, which is actually considered expert level after taking that course, that they can access.
That's awesome. That is so awesome. I love that you're doing that. Thank you. So now if someone watching has had their implants and whether or not they had it for reconstruction or enhancement, and they were listening to you talk and thinking, I really need someone like that in my life because I don't have full range of motion, I'm still having pain. Can they see you in some way? Are you able to help them in some way? I've got, on the screen here, I've got your information scanning. And so what would you do for them? How could you help them if at all?
Right. So I'm in North Carolina and licensed in North Carolina. So someone could come see me in my office. We could also do a telehealth visit, or anywhere in the world, we could do a coaching. I could basically coach them, where I can't provide treatment, but I can provide very valuable generalized information and help them with their next steps. So that might, consist of one or a couple of online sessions, just so that they can receive some clarification and some assistance with help.
Okay. Now let me ask you, for somebody like me who's, like I said, 2 years post explant and still having some pain here, not total, I would say, range of motion, are there any exercises you'd tell me to do, or anything you would give us a little sneak peek of?
Yeah, so you're talking about 2 years out, and this is great. I'm glad you brought this up, because one, I would be able to look at you specifically, like I would be able to look at your glenohumeral range and your scapular range and ask you questions and be able to differentially diagnose what nerves may be involved in my mind and things of that nature. But you also have to remember that it may not be peripheral. If you have had pain for 3 months, at least 3 months, then your central nervous system, your brain, is accommodating for that pain. Like, research has shown that if you have 3 months of pain, then you will have some level of depression. And so then we would start going into brain pain neuroscience and your pain story and the complexities of that pain, and start helping walk backwards and walk away from that pain. Because you can address it peripherally all day long, but if you don't understand how the brain is processing, pain is protective. And so it needs to be calmed down and understand, like, I don't need to protect you anymore.
Very interesting. Ooh.
Yeah. And I'm in a different, not a different fork, same fork, just not as trained. And so what I see and I'm not psychiatrically or psychologically trained, but the somatic experiencing is a big deal. And what I'm researching now is the rewiring post-explant, right? So the flares and the, like when you, let's just say you have a lot of the breast implant women are OCD, right? So if I ask, they're going to be the most compliant patients or clients ever. And if they say they're being compliant, then there's absolute trust there. And then they still have flares. So then you have to ask, what's the flare from? From some somatic to brain. And then you also think about core beliefs and the triggers and the mediators. Like there's a whole field that either is already being generated or can be generated from this. And you mentioned two things that, as I delightfully interrupt, at least delightfully for me, is what's interesting is that they've never tested the expanders or the implants in someone who's gone through chemo or radiation with them in. In fact, I think the labeling may say don't do this, but yet we do this, right? So there's that also, if it's going to make your muscles and your vessels maybe more stenotic and tighter and drier and blah, 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 why wouldn't it make a plastic or silicone or styrene or whatever is in these things the same kind of stiffness, right? And why wouldn't that be more advantageous for the texturized to just slough off, right? So there's that. I don't know if you have anything to say about that. And
what I have to say is I am always perplexed at how reconstructive surgeries vary per region based upon radiation or none. So, right. And I'll just speak from my experience, not my experiences, just my experience in doing research and seeing patients. I would not have implants in and or an expander in if I knew I was getting radiation. Do not put anything in my chest wall to begin with, and then radiate over it. Now, that I just thought was like common knowledge, but then like I am sad when rehab practitioners come to my course and they're like, and I present this and they're like, but they knew, but this is what, and they knew. And how am I supposed to say like, that's not right?
It's not okay.
It shouldn't be the standard of care in your area. And it, makes me want to call someone. And then also like, if you've received radiation to the chest wall, then I would probably be exploring microsurgery afterwards, not general breast implant subpectoral.
Or even fat transfer. I mean, we can get into all of that. Like
I know. And also another thing that blows my mind, and we're talking about like I've taught over in Australia and New Zealand. I show them images of my patients with radiation chest wall, and they're like, what?
Like, what the hell?
Why are you looking that way? Why are your faces confused? And they're like, we don't have patients that look like that anymore. I was in New Zealand. I was in Christchurch. And I was like, what do you mean you don't have clients that look like this after radiation? What are you doing? And they said, don't you use Mepitel? And I said, what? No, I've never heard of this. Why are we not using it in this country? Like, it is a shield that you place over your chest wall that basically prevents desquamation. And then I go to Australia. And one of the students is a breast cancer. I don't like the word breast cancer survivor. She had breast cancer. She ended up marrying eventually a surgeon, a plastic surgeon, such a compassionate man. But I said, show me your repair. It was beautiful. And I was like, well, we only have like a couple hundred, it was a microsurgical approach. I was like, we only have a few hundred, we don't have a whole lot of microsurgeons in our country, in the United States. And he was like, if you're doing plastics in Australia, then you understand microsurgery.
Yeah,
And
that's not the case in the US.
Tough with microsurgery. And then I'm like, oh, it's so sad that insurance is driving outcomes.
Mm-hmm. And we like to say we're so innovative here in the US, but
no.
Yeah,
that when mammograms
are way ahead of the game when it comes to surgery, treatment, rehab.
Wow.
They have a high BII rate as well, though. I must say, I went to Australia as well to study naturopath medicine with Elizabeth Lambert. But you know, like this is where the PTSD for me kicks in, because it's like, wow, this is a lot to affect, right? Like this is like just we're making change. And there's a phrase I love that it's like, not our daughters. It might have been our grandmothers, it might be us, but not our daughters, right? Like this is not appropriate medicine, and we can do better. I mean, it's freaking 2020, right? We can do better. The other thing I'd love to, if we can, it's a little bit of a digression and a little spontaneous here, but what I'm seeing in my BII clients, my autoimmune clients, my chronic fatigue clients, is a lot of, I'm going to call it pelvic floor dysfunction.
Ooh, let's go into it.
Right. And I am associated, and it's interesting because like different, and it's not like I have a huge N. I don't mean it like, ooh, I'm like this expert or anything, right? Like, I love it when I talk like my clients, like maybe there's 5, right? Like just let's set it straight. But like, okay, maybe there's 10. But of those 10, there's different quadrants that get affected pelvic floor wise, and they all have different personalities or core beliefs. I spend a significant time with my peeps. So like, it's not that I know what to do. I know of them, right? And we journey through this together. And what I'm finding really, really interesting, and Julie, who's in your class, is a great confidant and someone I can bounce things off of. But it's almost really where all this tension and hypervigilance began, and where I've developed a default mechanism. Mm-hmm. So when we think of sexual or painful, it's funny in my brain. I'm like, what was the medical term for this? Anuria, like, well,
dyspareunia.
Yeah, right, dyspareunia, and or atrophic vaginosis, or things that now you want to have sex and you can't, right? Like if you bear with me, and because I'm just putting this together now, when you back off of the physical, but you want to and you can't, or you want to and you're not that, and you want, like, it's the same core belief, core patterning, or verbal stuff that manifests. And I almost think that's the, no pun intended, the root cause. And if you want to get a little woo, that's like the root chakra and in the creativity zone and things like that. That's a big deal. And I'm almost thinking, let's go there first versus all of this. And that might release here.
Okay. So,
just simple thoughts.
No, it's great. So what I'm hearing is that you have seen an association between painful intercourse and breast implant syndrome.
Oh, yes.
Yeah. Okay. So
or explant. Let's say explant, because it shows up more in the explant people.
Explant people. Okay.
In the autoimmune people.
Things that are coming into play here. One is that your pelvic floor is a postural muscle. So have you ever gotten a headache when you're stressed? No, who has? But a lot of that is due to holding tension within the trapezius muscles, right?
Yeah.
A lot of people will tighten their pelvic floor without knowing it when they have undue stress?
Oh, I mean, think about the sphincter tightening. Like, what? You're talking about what? That's not me. That's not me. I'm fine.
And do you ever stop breathing? Do you ever breathe more shallow when you're stressed?
I breathe perfectly all day long.
Breathe shallow, and that's going to affect your pelvic floor excursion.
Yeah, for sure.
So in order to receive comfortable penetration, your pelvic floor is like a sling that's going, actually, let's bring out the pelvic model.
I love that
There's the pelvis. Okay. So
I was going to show you mine, but
what's that?
I was going to show you mine, but I thought maybe not.
Yeah.
This is better for right now.
You wanted things to go global, so yeah. So here is the pelvic floor. It's going from the pubic bone, and then it's slinging all the way back to the coccyx here.
Yeah.
And so this is the first layer of pelvic floor musculature. You can see the urethra, the vagina, and then the rectum. There's a second layer, which is primarily fascia, and then there's a third layer, which is like a hammock. Now these muscles, they support all of your internal contents. They stabilize you when you walk. They're very important for sphincter control when it comes to fecal and urinary continence, and then also sexual health, okay?
Yeah.
So this first layer, you can see that this muscle, these two muscles, bulbocavernosus and ischiocavernosus, attached to the clitoris. So these muscles, when you have an orgasm, well, they do become engorged as well as the erectile tissues behind it. But when you have an orgasm, they contract, pull on the clitoris, and that feels good. But then here's this basket of muscles here. So these muscles, whenever you relax your pelvic floor, then the vagina and the rectum open. That's really important for urinating, defecating, having babies.
Yeah.
The thing is that what would happen if I went around all day holding my bicep like this? The fascia would shorten, the sarcomeres would become short, okay? And then if you tried to just like pull my arm down, its normal set point is up here.
Right.
So you start to have a rebound effect. These muscles, we want them to have full excursion for maximal strength. If you are stressed and you are holding tension in your pelvic floor region, then over time, those muscles can shorten, but over a short period of time, you're getting less blood flow to the area. And these tissues around here, the vulva, it loves blood and oxygen. That's what helps it with lubrication. That's what helps it, like.
Oh, it loves all that and some other things.
Yes. And so the thing is that if I go around holding my tension in my pelvic floor muscles all day unconsciously, then I'm restricting blood flow to those tissues. They're not going to be as lubricated as they once were. My central nervous system isn't like go beyond the muscles and the ability for them to lengthen and open, but stress is not the best position to be in for comfortable penetration or intercourse. Like, people with penises usually can just blow on it and they're ready. Like, when it comes to other people that look like myself, usually we need to like feel good in our jobs and that our house is clean and that we have X, Y, and Z under control. So like, sexual health is so much more complex, but
exactly. And so certainly for the cancer patient, but also for the BII client, there's like, at least in some of the, like, it's so hard to just paraphrase, but you're waiting for the next shoe to drop, right? Like, I feel better, or I'm hypervigilant still, I don't, and that could be cell danger response. That could be inflammation because you have a yeast overload or blah, 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 blah. Like there's so many reasons why this could be. But I was really shocked to find how connected it all is. And it's not a topic we've been discussing in the BII community, right? And hopefully you have a loving partner, spouse or whatever, but it's even more primal. Like, so yeah, exactly, the stressors, right? Like, and that's just the first layer, but it is the primal of who we be as women culturally, and there's just so much more. And I think that if we're stuck in fight, flight, or freeze, I think that can get activated. So how do we begin to feel safe, gotten, heard, belonging as a community where we can just let it go? And then that's, creativity, blah, 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 right?
Yeah, and I'd also like to point out, I love that you're talking about community, and also intercourse is possible for most people, and sex can be incredibly therapeutic.
I'd like to sign up for that.
Yeah. Yeah, I mean, sex is a huge way that
oxytocin
and feel connected with each other.
Yes.
So you feel that connection with your partner, and it may not be like if the partner understands that we may be taking sex off of the table right now, just for this moment, and working on foot massages and words of affirmation, or love language, or moving into touch, and tell me what feels good. And then I have literally taken people from I can't have comfortable intercourse to I'm having the best sex of my life. And part of that has to do with partnership and connection. And so I'm not just working a lot of times with that female, but if I have a partner coming into the clinic as well that wants to learn about the pathophysiology of what happens with intercourse and what is safe, and also how to have a therapeutic effect on that region with intercourse or touch, then we're putting together a lot of the pieces. And people go from feeling like I'm broken and this is impossible, and this is a huge aspect of my quality of life that has been stripped away, to having hope, to partner, can you help me?
Or just be with me. Don't even help me. Just be there. And it doesn't even have to be sexual. Yeah.
But people do men especially like to know how they can help. How they can fix something.
That is true. And I will tell you from somebody who is married and went through the EXPLANT, they feel very helpless because we feel helpless. We get that hopeless feeling, and they feel like things are out of control, and they crave a way. Where do I fit in your healing? And so letting them in physically and emotionally, I think, is huge for their healing as well. So I think first of all, if you woke me up this morning and said that our conversation about implants was going to lead to vaginas, I would not have believed you at all.
Oh, it's so.
Wait for the summit, Tara. Wait for the summit, because it's all connected.
It's so connected. And there was a question real quick, because Danielle and I actually have another commitment that we have to do soon, but just a couple of things. First of all, I'm in love with you, Suzanne.
Oh, thank you.
I just want you to know that. And you're just a blessing. So, but we have one of the girls in my group, Mary, and she's wanting to know a little bit about detox. And so from my own personal experience, I did have someone who was able to help me work out some of the scar tissue, in this area, like rolling techniques and massage techniques, which actually sent me into a huge detox flare. So my body is holding toxins here. And then when I try to fix the pain or help the pain along or help the scar tissue, that actually sent me into a physical mess. I don't know if you can speak on that at all real briefly. I'd love to have like 3 more hours with you, but
Well, I was like, I wonder what we're going to talk about today. And then I'm just having such a fun time. And it really helps me think in a different way. But whenever you do scar tissue mobilization, okay, so when after surgery, you have a cut in the skin, the immune response is to go in and lay down fibers in order to create a patchwork effect and stop the bleeding. So this is literally what it looks like. It's just a big mesh, okay? Through range of motion, the immune system then goes in and it sends in macrophages, which are like little Pac-Men, to eat up any of those fibers that are restricting that movement. Now we can facilitate that with doing scar tissue mobilization with our fingers. That enhances blood flow to the region, but it also can promote a little bit of an inflammatory response. Not much. Like if I were to slap myself right now, it would get red, more blood flow, some inflammation. But for a system like your own that was in a place where it was like, I don't need any more inflammation. You
Please
know,
no more.
please no more macrophages. I just need
No cytokines. Yeah.
what that system needs is myofascial work. So that system needs a much gentler, more skilled therapeutic approach with probably an indirect release where we're shortening the tissue and we're allowing the fascia to unwind, and it's a much gentler process of remodeling.
Okay, that makes a lot of sense. Yes. Wow. I mean, I think you've blown a lot of minds.
Can you come back?
Yeah, I'd love to.
And for anybody who is still with us watching, I mean, Susannah is just one of so many amazing freaking practitioners that Danielle and a whole team of people behind the scenes are working on getting to the Breast Implant Health Summit, which is going to be October 24th and 25th, Danielle, am I correct?
Maybe 23rd, 24th, and 25th now, because we might be talking about vaginas too. Who knows?
I'll do it.
Yeah, I mean, because it is all of it. So
it is. This is a whole body approach. This is a trauma, physical, emotional shitstorm that we are, and Danielle has made it her life's work. Honestly, there are so many women.
No, just till the 24th. I can't handle life right now.
Danielle, it is going so far beyond that, and you and I both know it. You tell yourself what you need to, but it's going so far beyond that. But there are so many people behind the scenes trying to figure out a way to get you and practitioners to work together to heal your whole body. This is such a huge thing. Susannah, you're awesome. And thank you so much for being here. Thank you for what you do for your work with women. I mean, on behalf of women everywhere, I appreciate it. Danielle appreciates it. You're amazing. So keep kicking ass and kick pink. And
exactly.
So ladies, thank you for being here. We're going to go. Thank you everybody for joining in, and we will see you again, I believe, next Saturday. So take care, everybody.
Thank you.
Bye, guys.
Bye, Danielle. Bye, Tara.
Bye.
Bye.